Welcome to CareTalk, America's home for incisive debate about healthcare, business, and policy. I'm John Driscoll, the chairman of the Yukon Health System. Welcome, Jeff.
Hey, John, long time.
Jeff is the CEO of WellBe, a longtime friend and really an expert in the field of whole person care. So today we're going to go through a little bit of his clinical journey, the journey of sort of a managed care executive, a public servant, a successful big company bureaucrat, and now an entrepreneur. So welcome, Jeff.
Good morning, John. Looking forward to it. And we have a lot of commonalities. You're a big company bureaucrat also, so.
I'm sure I was very successful. I enjoy the entrepreneurial role a lot more. So, Jeff, tell me, how did you get interested in medicine? How did you become a doc in the first place?
Yeah, I don't want to digress too much, but it was really interesting. When I was growing up, I had the opportunity to visit my grandparents in China for the first time, 25 years, because, there was communist China. And, of course, you'd go and visit them, and first time, and they ask you, what are you going to do in your life? Then I was, 20 years old or something like that. And I said I was going to be a lawyer. And they said, why do you want to be a lawyer? That's the epitome of American capitalism. We're talking communist China.
Sure.
Why don't you be a doctor? The human body is the same around the world, and you can always come back and serve the motherland. And I stepped back and I thought about it. And, when you think about medicine, you're caring for everyone, regardless of race, religion, political affiliation. You're contributing to society, and you got skills that work around the world. So I switched up.
And so you become a doctor. Talk to me a little bit about that early academic journey, because I believe you specialized in geriatrics, which, although an exploding category, really doesn't have that many practitioners.
Yeah.
What got you interested in geriatrics?
Yeah, so once I made the switch to medicine, then it was really all about caring for people that need me. When you think about family practice, or pediatrics, you're fundamentally dealing with healthy kids, right? Adult medicine, a lot of it's prevention, wellness stuff. But when you really get into the geriatrics, you're talking about very complicated illnesses, people who are disadvantaged. I mean, I'm sure you've had a loved one. You can kind of picture it, 90 years old, frail, can't get out of the house, 6 or 7 diseases, 20 medications. What do those people do? I'm sure you've had a loved one like that, and it's incredibly frustrating.
And unfortunately, because medicine is so transactional now and so broken into silos, that whole notion of whole person care, particularly for someone who's got multiple comorbidities. My mother turned 91 on Friday, and it's extremely tricky. And we don't really, as a healthcare system, we aren't really well set up for that. And then you train in geriatrics. How did you end up getting to CMS of all places?
Well, before I get there, I just wanted to, you're absolutely right. Medicine's transactional. But so what happened was geriatrics. We discovered that the best thing for your mother, people like your mother, very frail, the best thing to do was to actually care for them at home. And the dirty secret of medicine is about 95% of what a doctor does in his or her primary care office can be done at home. Take a history, you do a physical, draw bloods, do an EKG. You can do practically everything at home. The only reason why we do it in the doctor's office is because of the transactional reasons you point out. You can see 20 to 30 people a day in the office versus in the home, which is the right thing to do. You still maybe only 4 or 5 people a day. And that was the challenge that I had. Every time this is like 30 years ago, we as geriatricians, we'd see a patient in the home, we'd lose money. because you only need maybe 4 or 5 a day. You weren't paid enough. You lose money. And so now you do the right thing, but it's just not financially sustainable.
But geriatrics, the other thing about geriatrics is it really does work. I mean, geriatricians actually, you look at the satisfaction of patients who are seeing geriatric doctors who have an orientation towards frail elderly, multiple comorbidities, the outcomes are actually very, very strong. You're building your clinical background. How did you end up in public policy at the Center for Medicare and Medicaid Services?
So it turned out what we learned 30 years ago is you could not support this kind of care, let's call it geriatric in-home care, in a transactional fee-for-service system. So we actually started the initial pilots, worked in many of the initial CMS pilots. That back then it was called HCFA. Now you and I are old enough. Remember Healthcare Financing Administration? But
yes,
we started in the initial demonstrations. One was the PACE program, which was originally off on lock. And then another one was called institutionalized SNP, which was basically care for nursing home patients.
Just contextually there, Unlock was one of the great successes of the healthcare program. All of your care was in one place. It was community-based. And honestly, Jeff, it was the Chinese American community or Vietnamese American community.
It's Chinese American in San Francisco.
But it was comprehensive care in one place and was the model for community-based care. And PACE, because all of the care was provided at whole person care in one place, also was incredibly successful at keeping people healthy and kind of happy as they aged in place. I mean, they were extraordinarily successful models. We talk a lot about what doesn't work in government, but both of those were great examples of what did work.
Yeah, and to your point, satisfaction was high, but they're really value-based care. And the way you can economically sustain the program was you did the right thing for patients. You took care of them at home in a community-based model. You lowered costs, and that's actually how you made your money. Not through more and more visits. It was economically viable because it's true value-based care.
And when people hear value-based care, Jeff, they often think about, well, there's some private sector incentive and there's businesses involved. There's just to this morning, there's a lot of news about United Healthcare potentially gaming the system. And I think probably others have gamed the system as well, although they appear to be in the crosshairs. You're really talking about the healthcare. I think you're talking about more the healthcare impact of the incremental invested hour or dollar. Is that the right way to think about it?
Yeah. Another way of thinking about it is since the true value-based care, you're both the provider and the payer. You're financially responsible for the hospital payments, the specialist payments. So if you can do the right thing and keep people healthy and out of the hospital or out of the emergency room, you actually make more money that way, which from a patient's perspective, it kind of is aligned incentives. I'd rather you take good care of me and do prevention and community-based care in the home and keep me out of the hospital.
Was it acknowledged at HCFA and CMS that this made sense?
So the PACE program was very successful, but really only covered maybe back then 5,000 people nationwide. ISNP program, same thing, maybe 5,000. So I actually went to CMS because what I really wanted to do was create the conditions where programs like this could continue to thrive and move beyond just little small pilots. So one of the things that we did at CMS, we're risk adjustment, we're V28 of risk adjustment. You just there are some abuses there, but the good in it is we developed V1 of the risk adjustment. And the good of that was for those providers or payers that really took on sick patients, they got adequate reimbursement. Versus, 30 years ago, if you were a payer, you got paid the same for everyone. Your goal was to just skim the healthy. right? And you remember that back then, right?
Yeah, and there are all these horrible stories, but we're talking about the managed care programs, and the difference is whether you paid the same amount for every patient, where unfortunately some of the health plans actually only enrolled healthy patients, and shifted to a place where the risk adjuster, where you were supposed to be compensated more for caring for more for patients with more needs, and hence took more time to give them the right care. The risk adjuster program, gosh, the concept was right, Jeff. Where did it go wrong? And then let's get back to what you're up to, because you're kind of an expert in this area.
Yeah. So, and I do want to spend at CMS a few minutes on the STARS program, which is really important. But no, I think the concept's great. And you actually saw a tremendous uptake of providers going into, I used to be the president of Chen Med. They deliberately put their clinics in a low income neighborhood. If you were like fee for service, you wouldn't do that, right? But the risk adjustment really does allow for people to kind of take on pretty sick people. Where it went wrong, quite frankly, is there's a difference in incentives when it comes down to coding. In the managed care world, the Medicare Advantage world, you're incented to collect diagnoses and record diagnoses. In the fee-for-service world, which is how CMS does is they compare costs between the two worlds, the set rates. See it in the fee-for-service world, the providers are incented to upcode on the CPTs. They actually have zero incentives to correct the right diagnosis.
I think what you're saying, Jeff, is there are perverse incentives in both fee-for-service, regular Medicare, and in managed care around risk adjuster.
That's correct. And if you had similar incentives to collect the right diagnoses, then everyone would be on a level playing field. But right now, it's different in the two programs.
Mm-hmm. And do you want to talk a little bit about how CMS tried to fix some of those incentives with the STARS program? Because again, and we're really very much focused on the managed care, because now 54% of all Medicare eligibles are actually enrolled in Medicare Advantage, or the managed care part of the Medicare program.
Yeah, I would actually argue that is the reason why, because when we started back then, this was way back in the Clinton administration, it was maybe about 10%. So now we're up to 50%. A was risk adjustment, but B, it was a STARS program. The other take, if you recall, the other knock on managed care 30 years ago was you're just denying care, you're not improving quality of care. So the second thing we did at CMS is we created Medicare HEDIS, Medicaid HEDIS, the CAPS, the member satisfaction survey. Those eventually became the STARS program.
Just so folks can track this, the HEDIS programs are really clinical measures of progress, and the CAPS are really consumer satisfaction, if you will, just crudely stated. And so by both looking at both how the Medicare eligibles felt about their care, and how then mathematically taking, standard clinical outcomes, were you making progress? And those foundational blocks that you helped create ended up creating something called the STARS program, which is honestly, it really drove the profitability of Medicare managed care companies into some of the fastest growing and most profitable businesses in America over the last 5-6 years.
Well, as you're aware, John, if you're a 4-star above, the CMS would actually pay a 5% higher premium, right?
But also, this is a business where 3 to 5% is the profit margin.
That's correct. But you see, from a public policy perspective, the way we thought about it back then was you do a risk adjustment so you get adequate payment for sick people, and you do the STARS program so you actually create incentives to improve care, improve member satisfaction. And if you actually, this is historical, but if you 20, 25 years ago, if you asked in the C-suite of a managed care program how much time they talked about quality and member satisfaction, it was 0. Now you ask the question in the C-suite, how much, you're talking about it like 60, 70%. It's all the time. But that's really good.
We've gotten the incentives, right? So where do you, I don't want to get too far off a field, but there is a fair amount of it, interest right now on the federal level. The Department of Justice is going after United Healthcare around the way they may have gamed the system, according to the Department of Justice, the premise of the investigation. Do you think the program is wrong, or some of the competitors might be wrong?
Yeah, I think it's as with everything. I think there are a couple of companies. I don't know. I don't want to comment on United, but there are people who let's call it abuse, the program. But I would not throw out the program. From a public policy perspective, it's the right direction to go. Even in traditional Medicare and traditional fee for service, there are people who abuse the system. They're upcoding.
100%. And in fact, if you look at the history of managed care, when managed care came in, inpatient days went down in Medicare, and emergency room visits went down. So actually people were getting better care on balance. So I think that's exactly right. So you're at CMS laying the building blocks of these systems, and then you end up coming out and joining the evil empire of managed care. So how did you then make the transition to WellBe?
Yeah. So look, I went to the payer side. Let's call it it's a Cigna for 9 years. I think my goal was to try to take some of these same Medicare managed care principles and move it into commercial health insurance. It's really tough in commercial health insurance. And I think one of the biggest challenges, quite frankly, is the health plan in the commercial health insurance world is really not the payer. They're a third-party administrator. It's really the employer that's the payer. And I think that's one of the fundamental structural issues. So then I got, there was only so much you could do on the payer side in commercial. So then I went to your former employees, Walgreens, there I wanted to learn retail health, or consumer health. That was an interesting experience. In a nutshell, I would say, I don't know how you felt about it, but I think in a nutshell, there's only so much that consumerism will do.
I think the other challenge, Jeff, is for people like you and I, Walgreens is such a strong traditional retail pharmacy culture that they have a very hard time reimagining. It's interestingly, even with its Boots was much more flexible than remarkably with an even older history in England around clinical care than Walgreens was in the U.S. And I just think cultures and leadership can be funny. And I think both you and I were trying to do the right things. We made some progress, but I just think I think it's also hard when the core business, Boots, was actually doing well on its own. Whereas I think the core retail franchise has really suffered because of the PBMs and getting your head around that correctly. It's harder to actually do anything novel in healthcare that's meaningful and substantial. But I know you did make some progress, but it's, Walgreens, has had its hands full on the other side.
No, it's very hard. It's interesting you mentioned Boots, because Boots, in an odd way, because it's in single payer countries, there was no PBM. So the payment rate was the same. So when you think about it, Boots was then, okay, how do I improve satisfaction? How do I add value to the patient so I get more retail sales, right? I mean, that's kind of Walgreens.
They found a way to actually get the NHS to pay. I mean, because it's much easier to do convenient care at a Boots than it is to add another primary care doc.
Yeah.
So then where did you go after? Did you go to ChenMed after?
Yeah, I went to ChenMed. Yep. As their president.
That just seems like a great model. You want to talk a little bit about their model of care? Because that's also whole person care.
Yeah. So the way I like to think about this, John, is I've came full circle, provider side, then to CMS, then the payer, then like big retail, now back to provider. I ended up concluding that if you really want to add value, it really is on the provider side, in particular in primary care. And then the other theme in my career was like serving the underserved. And I really like the trend. They deliberately put their clinics in low income neighborhoods, I mean, it's really funny. I mean, you and I are old enough. 20 years ago, we used to talk about the biggest problem in healthcare was access to care. And now we've moved there, but we haven't solved access to care.
No.
So the way I think about ChenMed is they put their clinics in Harlem or, south side of Chicago. You're trying to solve access to care. Pretty simple.
And so what drew you to WellBe?
So similar. So let's call it, you can put yourself in low income neighborhoods. That's one, or you can focus on, what we were talking about, the frail elderly patient like your mother. And then you solve their access to care by delivering care in the home. But it's a similar principle. It's just at the end of the day, care in the home for a very sick population is the right thing to do. What we were able to do, we had a very hard time making it work 30 years ago in that fee-for-service system. The one big difference is now WellBe, Senior Medical, we're a value-based provider. So we're both financially at risk for all the hospital care, and then we're basically supplying geriatric care or the equivalent of primary care in the home.
And your customer is first the health plan that's taking risk in Medicare, and secondly the patient. So how's it going?
Yeah, so the way it works is the health plan finds these really sick people and then assigns them to us, and then we care for them. Even if they have a primary care physician, think about us as the geriatric specialist caring for the patient, and patient gets to keep their primary care doctor, and we're the geriatric specialists. It's going quite well. I mean, we're currently about 170,000 lives in 9 states.
I love it. Are you finding that the doctors, the patient's current doctors, are threatened at all by what you're doing or nervous about what you're doing?
Yeah. So I would say the majority are not, because the majority, when you talk about what patients we're caring for, they would say, oh yeah, this Mrs. Jones or Mr. Smith, they really need help and I can't see them at home. And, I'm glad to have some help, Now I can still see them in the office periodically. Great. Okay. But I'm glad to have the help. Think about it as a primary care doc. Let's say you have a patient with bad end stage congestive heart failure. They're glad to have the cardiologist help them, So the majority are fine. Now there's a couple where it's threatening, but you saw that like in the retail clinics at Walgreens, right?
Absolutely.
And
absolutely. Jeff, you and I profoundly agree that this geriatric care and care in the home, delivering care where people want to get it, allowing them to live independently is the right way to do it. I mean, obviously I'm a believer because of CareCentrics, and I know it works because it's the only way actually to do whole person care is to see people in situ. I don't know whether they're more honest or things are just more transparent when you're actually in the home with patients who are vulnerable. But I've seen it, you've seen it, the folks at Devoted see it when they're doing their work, different health plans that really have gotten it right. Why don't you think why doesn't everybody flock to the WellBe model, the CareCentrics model? I certainly found it frustrating that I had to sell something that just made so much sense. What do you think the challenges are to actually convincing people that the WellBe model is the better model, the geriatric model is the holistic model, and that for these most vulnerable, most expensive patients, we can actually keep them healthier?
So the whole sector is growing now. There are a lot of new companies in this space. I think the plan are beginning to get very focused on this, especially since last year they had a lot of medical cost headwinds. And then when they do the analysis, they look at, wow, it was really these sick people, right? So I think the plans are coming around. I actually think the biggest barrier to why this model doesn't just completely take off is it's very hard from a provider perspective to take risk. It really is hard. I mean, you need financial backing and you need a lot of expertise. And doctors really, at the end of the day, aren't trained for this. Let's call it the business side of medicine, right? So,
well, and even more so the risk side. I mean, it's not just getting your bills paid. So one final question, Jeff. I guess if you had one thing to change in healthcare that would make the WellBe model easier to execute, what would it be? It could be on the regulatory side. It could be on the managed care side.
Ooh, that's a good question. One thing to change. I think the regs are probably, from a regulatory standpoint, are in a pretty good place. So probably on the plan side, I think that the plans get a little confused around this, and because they're approached by so many different other, what I would call point solutions, that split up the whole person. They have like a diabetes program and a prevention program and a palliative care program and everything. So probably it would be clarity on the health plan side, where it's in their interest to find whole person solutions. That's what the member wants. But then it gets them out of the business of trying to manage all these little point solutions. So I think it's the plans kind of coming to a strategy, which really is a little more around whole person solutions rather than point solutions. If that makes sense.
It does. And I think that's a great way to leave it. Jeff, thank you so much. Thanks for joining us today.
John, I've really enjoyed it. I'm sorry we didn't get a chance to spend more time on your experience at Walgreens and CareCentrix. Next time we'll have to flip the order here.
We could, happy to do it. I think we've had a lot of fun and some success at covering some of the same territory.
Yeah.
So if you liked what you heard or you didn't, we'd love you to subscribe on your favorite service to our wonderful podcast. Thanks so much, Jeff.